Our first speaker is Emily Dore, a postdoctoral research fellow at the Social Policies for Health Equity Research Center at the Harvard T.H. Chan School of Public Health. And she'll be presenting Association of County-Level COVID-19 Policy Comprehensiveness and Adult Behavioral Health during 2020 and 2021, findings from 3 national surveys. Okay, Emily, I will turn it over to you.
Hi, everyone. So thank you, Megan, for the introduction. My name is Emily Dore, and you just said findings from 3 national surveys. In case people are looking at the title, it's actually 2 national surveys. We're using restricted access data, so we had hoped to have our 3rd ready for today, but unfortunately we're not. We haven't been able to export those results yet. So I'll be talking about 2 national surveys. But anyways, yes, my name is Emily Dore. I'm a postdoctoral research fellow, like Megan said, at the SBE Center, a center led by Rita Hamad at the Harvard School of Public Health. And I'm presenting our work here on behalf of my co-authors that are listed here. Some results from analyses we've been conducting examining behavioral health effects of county-level COVID policies. So first, I'll go over the U.S. County COVID Policy Database, or UCCP database, which was mentioned earlier, which I believe you all heard about last year too from my colleague Caitlin, in case you remember. And then I'll share results from 2 of the studies that we've been working on that connect the UCCP database to the National Survey on Drug Use and Health, or NSDUH, and the Behavioral Risk Factor Surveillance System, or BRFIS, datasets. So the 3 aims of our study, which really center around the creation and then analysis with the UCCP database, has these 3 goals. So I'll explain the database a little bit more in the next slide, but essentially it captures county-level policies passed in response to COVID-19 pandemic. Our first aim was to categorize geographic and temporal variation in these policies, which again, my colleague Caitlin talked about last year, those results. Second, which is what I'll talk about today, we plan to examine, or we have examined the effects of these policies on mental health and other health and social outcomes by linking the UCCP database with national survey and administrative data sets. And then third, we plan to estimate the association of these county-level policies with disparities in healthcare utilization for mental health, which the team is currently working on using METS data. So before I joined SBE, which was about a year ago, a team of researchers created this UCCP database by retrospectively gathering weekly policy data from 2020 through 2021 on 27 individual policies, which I'll show you on the next slide, for over 300 counties across all 50 states and Washington, D.C. The counties are shown here in blue on the map and represent over half of the U.S. population. The 27 policies that were captured were grouped into 3 domains. So containment and closure policies, economic response policies, and public health policies. In addition to the individual county variables, the UCCP includes 2 summary policy measures by week for each county. So first, a count of how many policies were in place that week in each county. So for each of those 3 policy domains that I mentioned, as well as a total policy score. And second, a comprehensiveness score, in which the values are scaled to more granularly capture the comprehensiveness or restrictiveness of each policy domain. The data collection wrapped in December 2023 for the database. It is now available through the ICPSR website, and this QR code you can scan to go to that website and access the data. So here are the 27 policies that are included in the database, which we've grouped into the 3 domains. You can see containment and closure policies include policies like school closings, workplace closings, bar and restaurant closings. Economic response policies, which include things like income support, housing support, paid sick leave, and then public health policies, things like testing policies, contact tracing, and facial coverings. So those are examples of the policies. And so now that we've collected the policy data, the next step was to assess the effect of these policies on behavioral health outcomes, including things like drinking and smoking behaviors, mental health, and drug use. And we're interested in these outcomes because they tend to be more responsive and short-term to these policy changes. And while there's evidence of state level policies on these types of health outcomes, there are a lot fewer studies on county level policies and even fewer on public health and these containment policies compared to the economic policies. So we assess the effects of these policies on these health outcomes in an overall population from both data sets, as well as examining heterogeneous effects by subgroups. Though because of time reasons, I don't get into the subgroup analyses, but we can talk about those if you're interested. So as I mentioned, I'll present two studies that link the UCCP database with health surveys to assess the effect of these policies on the health outcomes. First, we examined outcomes using the NSDA dataset, again, National Survey for Drug Use and Health, administered by SAMHSA. This analysis was led by Emily Wright, another postdoc at SBE. And so for both of the datasets I'm going to be talking about today, we examined restricted use data because the UCCP database has county level policy data, and public use data is rarely available at the county level. So we linked the UCCP database with NSDA 2021 data and restricted our sample to only adults. And although we have policy data for 2020 through 2021, we only use 2021 NSDA data because there was a large disruption during the pandemic. So SAMHSA doesn't allow comparison between 2020 and 2021 data. The outcomes we examined were things like I mentioned, like cigarette use, alcohol use, drug use. Here I'm listing our individual level covariates for NSDA, age, race, employment status, et cetera. And then for NSDA, we also had these county covariates that captured some of the COVID severity data, things like mortality and admissions. Very similar for BRFIS, nationally representative, cross-sectional data set. We use the restricted access. We were able to use both 2020 and 2021 for BRFIS because there wasn't quite as much disruption during COVID, during 2020 at least. We looked at similar outcomes at parallel NSDA with some additionals like any exercise, number of poor physical health days, number of poor mental health days. And then we only had the individual covariates for BRFIS, again, things like age, gender, and race. Okay, so the exposure is maybe a little complicated, so I'm trying my best to explain it here, but again, maybe in Q&A, if you're still confused, I can try to explain it better. But so the exposure that we looked at, remember I mentioned there were those two summary scores that are included in the UCCP database, one for counts of how many policies were in place during each week for each county, and then this categorical variable that captures how comprehensive the policies were. So for example, for school closing, there were 4 levels of comprehensiveness. So no restrictions, no closings, which was coded as 0, or recommended closings for all schools open, but with alterations, which we coded as 0.33. It was from a scale of 0 to 1. Require closing only some levels or some schools, which we coded as 0.66, and requiring closing of all levels, which was coded as 1. So kind of, the most restrictive gets a higher score. Then we use these categorical versions of the policy variables to construct a past 8-week policy comprehensiveness score. So 8 weeks previous to the survey interview. So for each of the policy domains, again, the public health policy, containment and closure, and economic, and then for total policy comprehensiveness. Is there a way I can scroll down on my notes? Sorry. I need my notes for this explanation of the exposure. But I can kind of continue. So this is just fake data to give you an example, hopefully, of 10 weeks of the scores for the policies. So in this particular county, so imagine somebody was interviewed in week 10. We took the average scores of this policy score, comprehensiveness, for the previous 8 weeks, so week 2 through week 9. We took that average, and that was the policy. Oh, thank you. Policy exposure.
That's the bar there, and just click.
Perfect. Thank you.
No,
I probably could have, but invaluable. Thank you so much. So yeah, then we created these past 8-week policy exposure scores for the 3 domains and for total policy score, adding them all up. So then for the analyses, they're pretty similar across both data sets. We did linear regressions and linear probability models, depending on whether the outcome was continuous or binary. For NSDA, we just used the county fixed effects. For Burfus, we did use county and month fixed effects, but again, since NSDA is only 1 year of data, the month fixed effects really took away a lot of the variation in the exposure. And then we looked at, the question was, what's the association between the policy score comprehensiveness and the health outcome, controlling for the individual level covariates or the time varying county covariates, as well as the fixed effects. Again, looking at the overall sample and then stratified by different demographic or county level characteristics. As you can see, NSDA had a smaller sample size, around 26,000, versus Burfus, which had about 270,000. And NSDA, because of restricted reasons, I can't tell you how many counties actually matched up with UCCP, but for Burfus, we were able to link to all 309 counties. There were individuals from Burfus in all 309 UCCP counties. So these are the results from the analyses on the total sample for NSDA. And just to mention, this paper was recently accepted for publication by the Journal of Urban Health, so make sure to look out for that. But each rectangle includes results for one health outcome, but two models. So the filled in circles are the models that include the three policy-specific scores, so the containment, public health, and economic. And then the circle outline just represents the models with only the total policy comprehensiveness score as the only exposure. So you can see in these results, in the overall county fixed effects models, the policy comprehensiveness scores were not associated with significant differences in the behavioral health outcomes assessed for any of these different policy scores. As for patterns, we found increases in containment and total policy scores, so more stringent containment and closure policies were associated with small, non-significant increases, so more psychological distress, more substance use, in all but one of the behavioral health outcomes, which was the any marijuana use. So generally sort of negative effects of the containment exposure on behavioral health. Meanwhile, increases in economic, so more generous economic support, and public health, more comprehensive public health measures, were both associated with small, non-significant decreases, so improvements in most behavioral health outcomes. So that's NSDA. And these are for Burfus. These are the results for this full sample from the fully adjusted county and month fixed effects models for Burfus. Unlike NSDA, we did find some significant relationships between the policy comprehensiveness scores and health outcomes. Specifically, we found that greater containment policy and total comprehensiveness was associated with lower likelihood of any alcohol use and fewer poor physical health days. And greater containment policy comprehensiveness was also associated with lower likelihood of any binge alcohol use. So sort of positive effects on mental or behavioral health of containment policies. Economic and public health policy comprehensiveness scores were not significantly associated with any of the health outcomes in the overall sample. However, the patterns showed that in general, the economic policies were associated with better health outcomes, like lower likelihood of being a current smoker and fewer days of poor physical health. And for public health policy comprehensiveness scores were associated with worse health outcomes, like higher likelihood of any alcohol use and more poor mental health days. So again, these are not statistically significant differences. So in conclusion, the strongest evidence we found was in Burfus that containment and total policy comprehensiveness was associated with health outcomes, in that more comprehensive closure policies were beneficial to health, especially alcohol use and poor physical health days, which may be because people were less likely to go out in places with more closures, meaning they're less likely to catch any illnesses from others in terms of COVID, but other illnesses too. And perhaps the closure of bars and restaurants also led to less alcohol consumption. However, NSDA findings were opposite for these containment and total policy scores, instead showing they had these negative impacts on health, again, though not significant. And they might be not significant because there's really no relationship, or maybe because NSDA's sample is smaller relative to Burfus. And for all the outcomes where we find these discrepancies between the two analyses, it's important to remember NSDA is only capturing 2021. whereas BRFIS is capturing 2020 and 2021. And so reactions to these policies may have changed over the course of the pandemic. And the variation is a lot of the ending of these policies too. So the other more suggestive evidence was that in both data sets, we found beneficial, though again, insignificant relationships between economic policies and health outcomes, which these findings parallel results of studies on state level economic policies, which generally find more generous economic policies are beneficial for health. But to better triangulate these results, we're continuing to look at different data sets, specifically NHIS, MEPS, and Medicaid data, and connecting similar types of outcomes with UCCP database. So stay tuned for those results. I just want to acknowledge collaborators on these projects, as well as the policy data collection team, and of course, our funders. And thank you so much for listening.